Yeah, now I can.
Okay. Then please start.
Yeah. Hello, everyone. We welcome you to this session on genetics. And this is a very important topic, especially for fertility consultants who are dealing with a lot of microTSA or even like TEFNA and patients who have male factor issues. And I think somewhere we kind of forget that this is a very important aspect of male fertility evaluation, and this should be one of the evaluation factors that we need to consider even before going ahead and doing an ICSI or going ahead with procedures like microTSA, PISA, or even the TEFNA. So genetic factors, as we all know, I think they play a crucial role in male factor infertility. One is like to attribute as to if there is any genetic factor at all which is causing the male factor, and also whether it is transmissible to the fetus. So these two things are extremely important when we talk about genetic factors. And I think the practical points on this topic will be given today as to when to do, what to do, and whether it is worthwhile doing, and what counseling needs to be done in terms of like using the self gametes, or whether to go for donor gametes. So over to you, sir. You can start your talk.
Thank you, Shilpa madam. And as everybody has said, hats off to your commitment. Continuously taking lecture after lecture after lecture, and now we have reached 71. I also want to congratulate all the viewers because today in the masterclass we'll be finishing 1 million views for the fertility masterclasses. So it's a great thing, and I'm very happy actually. So this is a very important topic actually. Male factor, genetic evaluation of the male factor. What is important about the genetics of the male factor? Just if I can finish off the masterclass in exactly 1 minute before my network goes away. Okay, and one take home point which every individual should have in this lecture is that do not do an unnecessary genetic evaluation when you think there is oligospermia, when you think there is teratozospermia, when you think there is asthenospermia, or when you think there is a combination, severe oligoasthenoteratozospermia, when you think there is something like that, all right, the first thing you should do, first thing which you should do, which nobody does, and that's the take home point, is examination of the external genitals of the male. All right, that's the most important thing which you need to take home. See, if the external genitals of the male, just remember this rule. If the testis is slightly small in size and slightly soft in consistency, okay, that is one of your primary indicators of going ahead for any genetic testing, which will give you some worthwhile results. Okay, otherwise you can just do a genetic testing stating that acha sperm count was less than 1 million. Kindly evaluate the male partner for Y chromosome microdeletions, because this Y chromosome, why you are giving so much importance to Y chromosome? The answer is there is something called as Sertoli cell factors. Okay, there is an entire region on the Y chromosome which controls the sort of the genetic arrangement for the Sertoli cells. Okay, and these Sertoli cells are the cells which are responsible for taking care of the primary spermatogonia and converting them into secondary spermatogonia, forming the primary spermatid, and then finally forming the sperm. Okay, everything is going to be controlled through the Sertoli cells. Okay, which is why this Sertoli cell factor, which is present on the long arm of the Y chromosome, it is very, very important. Long means which arm? Remember last lecture, Q. Okay, P means petit. That stupid French people named it, no, like that. Okay, so this Q is the long arm, and that's where these factors for fertility are very, very important, which you need to keep in mind. Okay, in that also, don't get confused. Okay, there are just three factors, there are not 33. It's male genes, no? So everything is going to be very simplified. Even God has simplified everything for males, no problem. Only three factors you need to remember: AZFA, AZFB, and AZFC. It's like an MCQ where God has not even given option D. Understanding? In that, AZFA and AZFB are very bad. So if you have microdeletion of AZFA and AZFB, that means तुम कुछ भी कर लो, you do whatever you want to do, you will not be able to find sperms properly. It will come out to be Sertoli cell syndrome. Okay. If you have AZFC as a microdeletion, all right, then in that situation you will be able to find some sperms. But when you are able to find some sperms in an AZFC microdeletion, okay, then it should be important to understand that you have to go ahead and do PGTA for that embryo, because if it is a male embryo, then it is going to be 100% transmission, it is, which is going to happen inside that male fetus. Okay, so keep that in mind. Apart from this, okay, apart from this, where your karyotyping will help you, okay, it will help you in the other genetic causes, for example Klinefelter syndrome. But remember the correlation. Klinefelter syndrome has a very small size testis, which is why I mentioned size of the testis and consistency of the testis is very important before you go ahead and suspect a genetic sort of a makeup. Okay, Klinefelter syndrome, very soft testis, very small testis, the guy is going to be tall, you can suspect Klinefelter syndrome. There is going to be a 5 to 7% sperm retrieval rate. Okay. After that, you have something called the Superman syndrome. You know, it is basically Jacob syndrome. That is, instead of Klinefelter, where there is XXY, in Jacob syndrome, there is XYY. Okay. Remember, this is one condition, XYY, where testicular palpation is normal. Okay, the minute you put the needle inside the testis, you will find the sperm. But even this guy needs to go ahead for a PGTA. How will you diagnose Jacob syndrome? Same like Klinefelter syndrome. Tall guys, strong, well-built guys, testis is normal. Okay, 90% of the times when they are having azoospermia, this is the other spectrum which people miss out on. We've published 7 pregnancies. We have not published, to be honest, but we have had 7 pregnancies so far with guys with Jacob syndrome. Okay, and we have a master class for patient education on Jacob syndrome, on which we get maximum number of our patients from YouTube, you know, all across SARC countries. Okay, so we have had 7 patients who have conceived post Jacob syndrome. So just keep that in mind. That is the other thing which you need to know as far as genetic evaluation of the testis is concerned. Okay, and then comes the other evaluation where there is nothing to do with the sperm. Okay, so that is your karyotyping of the male partner, which is your standard G banding karyotype, which you need to do in order to look out for any translocation, in order for looking out for any deletion of a short segment, long segment of any autosome or anything else. Look out for inversions, because those are the factors which are going to give rise to formation of either poor quality embryos, or those are the factors which are going to give rise to either recurrent pregnancy losses. Okay, so that is something where you also need to evaluate the male factor for a genetic cause. Remember, the semen analysis in them is going to be normal. Unless you have the Y chromosome which has been altered, the semen analysis is almost always going to be normal. So this is your other subset of males where you have a normal semen analysis. Okay, and you are still doing a genetic testing. The prior subset which I mentioned is where there is either severe oligoasthenoteratozoospermia or there is non-obstructive azoospermia, and in that you are doing genetic evaluation which is predominantly related to Y chromosome. Okay, fine. Now this much is done. Now, how do you treat all these things? Okay, is there any way on earth where you can go ahead and treat a genetic factor? The only genetic factors which you can probably prevent from getting transmitted are basically your Y factors. Okay, so people with Klinefelter, people with Jacob, and people with Y chromosome microdeletions AZFC. Apart from that, there is no other genetic cause which can be rescued. Okay, and getting chromosomally normal embryos is a big challenge in all these things, because you are going to get very less sperms, and getting very less sperms means you are going to get very less embryos. So the guy has to be really lucky to form a euploid embryo. It's a luck factor. Okay, and then that lucky guy is able to have a child without any genetic inheritance of the same. Okay, fine. Is there anything which you can do in order to ensure that you're chromosomally, if there is a chromosomal abnormality on the routine karyotyping on G banding, can you change it? Translocations are something which you can probably avoid by doing a PGTA. Apart from that, nothing can be done to change the genetic makeup of that particular component of the haploid chromosome which goes inside the sperm. Nothing can be done. Okay. So this is all that you need to know as far as genetic evaluation is concerned. Shilpa madam can ask some more questions. Hopefully, I should stay in network and able to answer you guys.
Okay, so tell us this Klinefelter syndrome. Like if at all, if the patient gets pregnant, do we routinely do the PGD and amniocentesis for all patients if they conceive?
Absolutely not. Absolutely not. You should do PGTA.
Okay.
Put a chromosomally euploid embryo in that lady.
Okay. And in your center, do you advise karyotyping for all patients? Like, what is your cutoff? The count, motility, or morphology? What is your cutoff?
Forget the count, motility, and morphology. Go ahead and palpate the testis.
Okay.
See, remember one thing. There is not a big difference between sperm count being reported as 2 million and 0.2 million. Both are equally bad, madam. Both are severe odds. Both are severe oligoasthenoteratozoospermia. In that, there comes your clinical examination. Trust my word. Soft testis and slightly smaller in size than normal. Okay. There is only one factor which comes along with all this, and that is very severe obesity, which is very common in our country, which also gives rise to a slightly smaller testis due to higher estrogen, and it also gives rise to a slightly softer testis again due to higher estrogen and less testosterone. Okay, but what typically happens is it is very uh, it's not so common for a guy who is severely obese to have severe oats also. Of course, that combination is there, but it is not so common. There are so many obese guys who have normal sperm counts. In fact, there is a bigger problem once you do bariatric surgery. Because once you do the bariatric surgery, there is a sudden loss of testosterone and estradiol due to metabolic changes. Your testosterone to estradiol ratio changes drastically. And what people think that, oh, after bariatric surgery, sperm will become absolutely normal. It's not like that. After bariatric surgery, also, the sperm can stay very bad because of the prolonged estrogen which has been present due to the peripheral fat, okay, of bariatric surgery. So just keep that in mind.
What about undescended testes? I mean, do you attribute it to a genetic cause?
No.
And Kalman syndrome, as in like, is it like something which you have seen in your practice?
Which man?
Kalman, it's okay, leave it. Now, please don't make fun of it. It's fine. Let's move on to the next one. Yeah, so you think like, see if what is the alternative for clinical palpation? Is it like, an ultrasound where we do a scrotal scan and say that the testicular volume, we take it as a criteria?
Total scan is a very subjective thing. Okay, even if you measure the testis accurately in all the planes, somebody else will measure it equally well in a different plane. Understanding? So scrotal scan is not something which you rely on. On top of it, in scrotal scan, you will not come to know the consistency.
Okay, what is the role of this CFTR gene?
We don't do it.
Okay.
It is only and only indicated in cases of absolute asthenozoospermia, madam. Only when you have absolute asthenozoospermia, zero motility, just in case you are suspecting something like you are unable to differentiate between necrozoospermia and absolute asthenozoospermia, maybe you can try to look out for a CFTR gene mutation because it is, it is a factor for other ciliary motility problems,
Okay. And in your practice, what are the commonest genetic abnormalities? Is it Y microdeletion? Is it Klinefelters? Is it Jacobs? Like in your practice, what do you come across frequently?
Why my commonest?
What is the cost of this Y microdeletion test?
6,800.
Okay. So how is it? Like, is that a microarray?
No. It is just like a banding technique, madam. Just a little advanced banding technique is used for the particular Y chromosome. They have to magnify it little more. They don't do a microarray routinely for that, madam.
Okay, yeah. I think, yeah, that's all I have to ask. So I will just check in the
In
chat.
fact, in Y chromosome microdeletion, no, madam, they have to use a probe to tag those factors. Actually, AZF, A, B, and C, no, those regions need to be tagged because they are going to be, they are going to be reported as no abnormality found in AZFA, no abnormality found in AZFB, no abnormality found in AZFC. Like that, they will write down. You know.
Mm. So in all cases where you find the genetic factor, so you routinely do a PGTA for all
It's
these.
mandatory.
Okay, okay. Yeah, I think you should just rest for some time. Thank you so much. Thank you for doing the class from the Express Highway. Superb. I mean, it was a very good one. Thank you. And
Okay,
congratulations.
madam, just one thing. Somebody has asked a question, is elastography routinely done on the testis? Answer is no. Answer to that is no. Okay. So in order to routinely do elastography on the testis, you need to have a pressure gradient on which the testicular tissue would be, giving you an elastographic heat signal or an elastographic map. It's impossible to do that on anybody else's testis. Trust me. Okay. So just that's the reason why probably it's not done routinely.
Okay. Yeah. Thank you. Thank you so much.
Okay. Bye.
Right. Bye. All the best for Agra.